we are going to do the first test, that is passive horizontal adduction. So we have taken the things in here and then push. If there is any pain, then the passive horizontal adduction is positive. Now what are the reasons behind that? There are three reasons. It can be AC joint, it can be subscapularis tendinitis, it can be subcoracoid bursitis. Now we will go for active and passive, both arm elevation. First one was active, second one is passive. If we found any painful arc at the end of the shoulder elevation, then we think about AC joint. At the same time, we go for passive lateral rotation, passive medial rotation. If we found any painful arc or in-range pain, then again it is AC joint. If we found the local palpation is painful, then again it is AC joint. Now the second one, we are thinking about subscapularis. So we go for resisted medial rotation. If we found any pain, then it is confirming about subscapularis. If we don't found any of those, then we are thinking it's an subcoracoid bursitis. Now there is another one problem it can happen, that is anterior capsular adhesion. So if there is anterior capsular adhesion, this test can be positive also. So what we are going to do, we are going to do passive. We are going to do two passive external rotation. First one from neutral position, second one from 90-degree abduction. If in both cases it is painful, that one is anterior capsular adhesion. If the pain is only in neutral position but no pain at 90-degree, then it is subcoracoid bursitis. Alright, sir? Then we are coming for anterior apprehension test. So we are holding his hand in this position, our one hand holding his ipsilateral hand is holding his forearm and contralateral thumb is targeting his posterior border of the humerus, and at the same time we are doing two motion. One is external rotation and another one is anterior pressure over the humerus. If the patient give us subjective apprehension, then the test become positive. Then the second one, we are telling him to sit over here. Alright. Then we take the hand in this position and fix it over the anterior humeral head. We are doing two things simultaneously. One is we are pushing his hand in towards the medial rotation. At the same time, we are pushing his humeral head towards the posterior. At this time, if the patient give us the subjective apprehensive feelings, then the test become positive. Good news is 70 to 80% time the anterior apprehension become positive. Only 20 to 30% time the posterior apprehension become positive. Then we are going for press against the wall. Why we are doing this test? We are going to do this test for the mononeuritis of the long thoracic nerve, which gives nerve supply to our serratus anterior. So the patient is, I am a wall, so the patient is going wall push-ups. Good. During this wall push-up, if the scapula gives winging in one side, then the test become positive. It's not two side. If it is one side, then the test is positive, because if it is two side, then we think about upper motor neuron relation or some other things, because long thoracic nerve is a peripheral nerve. It cannot be affected both sides together without any trauma. Alright? Then we are going for press wall is done. Then we are going for
Scapular.
Scapular outcome. Okay. This one is for spinal accessory mononeuritis. So we tell the patient to adduct their scapula in last border, and we are taking our two thumbs over the medial border of the scapula. We hold the medial border of the scapula and push it towards the outerward. During this pressure, if there is any mononeuritis of the spinal accessory, then one side would be weaker than the other side. And why it would be weak? Because the spinal accessory nerve gives direct nerve supply to the middle and lower trapezius. The upper trapezius is mainly supplied by C4, so that one is a shoulder test by the, what is that called? This one is shoulder elevation test. So this one is for lower and middle trapezius. After that we are going for horizontal adduction test or horizontal press. So namaste. We hold the arm in this position and tell the patient to push by both sides. If there is any mononeuritis of the nerve to pectoralis, then one hand would be traveling to the other side. The side which side the arm is deviated, that side pectoralis is weak. If it deviates towards the right, right pectoralis is weak. If it deviates towards the left pectoralis is weak. Alright? Now we are going for another one test, which one is called anti-flexion. This one is rare type of coracobrachialis. So we take the arm in this position 10 to 15 degrees. We hold it and push it towards the posterior side. In this moment, if there is any pain from coracoid process to the medial 2/3 of our humeral area, then it is coming from coracobrachialis, but still we are not sure. So what we are going to do, there is a short head of biceps. So we are doing this test in two positions. One is bend arm position and adduction. Do the test. Go, 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 go. Okay. And another one is open arm and then adduction. Open arm and go adduction. If with the open arm time the patient gets the pain, it can be short head of biceps. When it is about the bend arm and the test become positive, then it is confirmedly coracobrachialis. Now one test, during bend arm it is coracobrachialis. During straight arm it is short head of biceps. Any kind of bend, 10 to 15 degree, whatever the bend, that doesn't matter. Now we are going for last one test when we cannot define if it's a supraspinatus or if it's a deltoid. We take his hand in this position, we come from the front. Okay. Alright, now push towards the backward. Alright, now push towards the same arm. Go towards the forward and change the arm, go towards the backward. If any pain comes from forward or backward, the problem is coming from the deltoid. If there is no pain in this position, but still your abduction is painful, that problem is coming from the supra. That's all about accessory test. Alright.